will participate to the discussion. So we are going to have Russell Taylor, that is professor of medical robotics and computer integrated surgery at Johns Hopkins University. And his talk, the title of his talk was Autonomy and Intelligent Control for High Dexterity Medical Robots. And then we have Elena De Momi. She's professor of medical robotics at Politecnico of Milano. The title of the talk is AI for Planning and Control of a Steerable Catheter to Treat Brain Tumor Disease. And Madi Tavaccoli, professor of robotics and medical robotics at University of Alberta. The talk is Intelligent Control and Artificial Intelligence for Enabling Robot-Clinician Cooperation. And Simon Di Maio, research director at Intuitive Surgical. The title of the talk is Surgery in the Age of Computing. Ken Goldberg, professor of robotics and automation at University of California. And the title of the talk is Superhuman Bilateral Surgical Peg Transfer Using Deep Sensing and Deep Recurrent Neural Networks. And Alberto Rezzo, that is a physician and associate professor, expert of minimal invasive surgery, flexible and robotic digestive endoscopy at University of Turin. So thank you for your participation and for the very interesting presentations that I think the audience had the chance to follow in the breakout room. I also thank the audience, and just a few words on the organization that was already explained by Farshid and in the previous panels, but just to recall how it is going to work, the discussion. So actually, we are going to ask some questions to the panelists, and we hope that the audience can also join with questions that in the first part of the discussion they can interact by writing the question in the chat. But at the end of the discussion, we will open to live questions, and so we strongly encourage the audience to participate. And of course, we are going to ask some general aspects that are related to control and intelligence of robotic system, but the questions, I mean, can be also specific on the presentations, on the talks of the speakers. And so I saw, of course, all your presentation that I have to say that they were really interesting, and so focused on the cutting edge research in surgical robotics. And I noticed that almost all your presentation were showing the picture of the paper of Science Robotics, the paper of on the autonomy level of surgical robots. So my first question is, let's say, a classical question related to control, but it is still an open question, and is related to the autonomy of robotic systems. So during the years, we had a lot of improvement about the technology from a sensing point of view, mechanical point of view, but actually most of the robotic system, the control paradigm is still teleoperation. So one question arises about the potential. So are potentials of those robots fully exploited? So the first question is about what is your vision on the future of autonomy for dexterous surgical robots? And I mean, everyone that wants to start the discussion is welcome. So maybe, yeah.
I think we all have strong opinions about this, but I'll share my thought, which I mentioned in the presentation, which is that I think it's very important to clarify for the public and even maybe for our colleagues that we're not, when we talk about autonomy, we don't mean full autonomy, that we mean partial supervised autonomy. And the analogy I like is to driving, and you talk about the 5 levels of autonomy for driving. there's the same thing is true for surgery. And so Animesh Garg calls it cruise control for surgeons. And that means I like that a lot because that's how I think of it, is that these are subtasks that can be performed under close supervision of the surgeon, but they can relieve the surgeon of tedium and also provide a higher level of consistency, let's say in the suturing. So I'm curious how the others feel about that. But I think that's where I see a lot of possibility, but it's very different. And in a lot of the press reports, robots are doing surgery as if, the surgeons are going to be out of work.
Yeah, I agree with you. And I mean, the nice thing of this panel is that we have different, scientists with different backgrounds. We don't have only engineers, but we have also a physician, and we have also a research from industry. So it is interesting to see the point of view also of physicians and of the industry respect to this issue. So can I ask Alberto?
Yes, no, sorry, can I just add something on the scientist point of view?
Sure.
Yeah, with respect to what Kenneth just said, so it's not only the cruise control, I think it's also the automatic braking system. So when you, for example, you just want to prevent doing something, so you have an automatic stop, for example, that's the same thing. So as much as you increase the safety of the intervention or the autonomy, I think it's more than welcome.
I'm going to just chip in a little here too. I think it's very important. Can people hear me? I'm sitting outside waiting to get into a hotel.
Can hear you, yes.
I think one thing to remember is that computers and robots have in some ways been autonomous as long as they've been around. The computer has always been making decisions. I think they're often, if what the robot is supposed to do is very clear, then the computer has done the rest. In the case of Dexterous robots, the control levels, the lower level manipulation levels are more complicated, and the computers are already doing more. But again, I kind of agree with Ken that there are different levels. I don't like these levels, but mostly what we're dealing with is various forms of supervised autonomy or cooperation. I think for us researchers, my personal opinion is we're putting too much attention into suturing and cutting and not enough attention into other assistive tasks that right now surgical assistants or the resident are doing, things like autonomous aiming of the endoscope for you, or maybe retraction is something that I think perhaps might see practical deployments of what would be viewed as more autonomous assistance sooner. So that was my comment anyhow.
Okay, thank you. So I was wondering, so what do you think about these 5 levels of autonomy? So do we have right now robots that falls within, let's say, the second, third level?
In my opinion, that's the wrong question to ask. I think we're spending far too much time on the focus on trying to draw the analogy to these levels that people invented to describe driving. There really, as I said in my video, 2 basic questions. Can we tell the robot what the robot is supposed to do in a way the robot will understand it? And second, can we be sure that the robot will do what the robot was asked to do and not something else? And I think if you look at all of those levels, however you partition them, it really does come down to those 2 questions. I think when you're dealing with surgery, in order to understand more complicated tasks, the robot needs more understanding of the surgical workflow and of the anatomy that the robot is working on. That's personal opinion, but I don't know how many of these workshops I've been in about the last 3 or 4 years where we spent a lot of time worrying, is this level 3 or level 4 or level 2.5? Personal opinion, but we're supposed to be controversial. So there.
So maybe I can add. Maybe I can add a note to what Fanny mentioned. I'm also one of the organizers of this session. So again, thanks everyone for being here. So quick question is that, are we thinking about moving toward I don't know what's the best name, but are we thinking about moving toward a full autonomous solution? Or, I mean, I understand that maybe it's not the best idea to go like level 1, level 2, level 3, level 4, but the direction, the future, the vision of the field, are we thinking about going for partialized segments of the surgery to be automated as a stepping stone to go toward a more, I don't know, longer term format of autonomy, or that is the, I don't know, that's the end of the line. I want to make different partitionized, I don't know how to put it in wording, levels of autonomy. So is it a stepping stone where we are right now, or yeah? Maybe if you can comment on it, that would be great.
Well,
maybe
some other people should. Yeah, go ahead, Simon.
Yeah, maybe I can offer kind of another way of thinking about this, kind of a layered approach, right? So we've been thinking about levels of autonomy, and it's kind of focused on the manipulation aspects. But I think if you kind of zoom out, you can think of a few other layers, right? So you can think of starting with things that are perhaps non-mission critical. If you think of the entire workflow of a case, you can think of various aspects of automated planning and assessment. Preoperative planning, segmentation of models, surgical aids, and even kind of post-operative feedback, which are kinds of things that are happening already, right? There's already AI and automation happening in those steps. There's another layer, which is starting to delegate some of the decision-making, right? So decision support, augmented intelligence, maybe navigation support. There's some of that happening, right? You'll see that in navigation of endoscopes, which path to follow to get to a bronchial structure, what tissue structure am I looking at, which vessel should I clamp, things like that, where you're starting to see some automation in that decision-making in collaboration with the human in the loop. And then you kind of get to that next layer of this problem, which is perhaps performing small subtasks in an autonomous way. It might be, like Russ said, help control where I'm looking, like autonomously with my scope, kind of a lower stakes, lower risk layer to the problem. It might be like firing a stapler. And so this is an existing piece of autonomy in the Da Vinci system in a way, which is to automate the clamping and firing of a stapler by kind of detecting tissue properties and optimizing clamp forces and detecting errors in a way that a human would find difficult. And that seems like a very small thing, but it's a subtask that happens in conjunction with the human. And then you kind of get that layer of, okay, now there's more extensive shared control and collaboration where perhaps, as one of the speakers spoke of earlier, some degrees of freedom are managed autonomously by an algorithm and others are managed by the human. And then that layer of full autonomy. So I think if we think of kind of from a functional sense or a kind of a clinical sense of what needs to be done, there are various places where autonomy can come into play. And that to me is more intuitive than thinking about, these kind of levels 0 to 5, which loosely map into that framework, but I think are more intuitive relative to the task.
Yeah.
And I'd also point out there's no one size fits all. What's autonomous for targeting a needle is going to be very different from doing suturing on the beating heart. So just my
I can jump in and add something. I think, Farah, to your question, I think there are this question becomes two questions. Is it desirable to have full autonomy, and is it feasible to have full autonomy? So I think the first question, that's an ethical issue. That's a clinical uptake and acceptability issue, and whether the society is ready, the clinical community is ready. I think that's one question. And then the other question is, technologically, is it possible, and are we there yet? So I am actually thinking along the lines of what was discussed, that you need these semi-autonomy at this point. You need to slowly go up this ladder of autonomy. for non-mission critical or mundane aspects of job, why don't you delegate it to the machine? If somebody has to hold an ultrasound probe for like the duration of the operation and track a needle as you're inserting it, maybe, why can't you delegate that? Or where there are things where the sensory motor capabilities of humans are not sufficient, like beating heart surgery, why don't you automate that aspect of motion compensation robotically? But to me, these are kind of two different questions that I just wanted to say, the feasibility versus desirability of automation.
Great to hear from Dr. Retzer on the desirability part as a potential user of this technology.
Yes, I'm the clinician, in case you didn't understand that. And that's why I'm scared to interrupt you. First of all, let me congratulate to all of you. I think I got about 25% of your presentations, and I'm very happy with that. Because really we speak different languages, and that's completely my fault. So I perfectly understood that you're all outstanding speakers. Ken, don't blame me. You are fantastic in explaining very easily also to us surgeons the things you're doing. I appreciated that very much. So probably I should interact a little bit more with you and tell you that with the eyes of a surgeon, the examples that you produced today seem not really so much realistic, and the effort you are producing is huge, but I'm afraid that this would not meet exactly the expectations of surgeons. Start from the definition of surgery. What we want is to have tissue manipulation. Otherwise, we can call it just ablation. So you can take out the circle just by radiofrequency if you accept this observation, again, with the eyes of a surgeon. And again, I congratulate with you because the examples that you have presented, the examples you presented were fantastic to start a very practical discussion.
Russell, can you mute? Okay.
So what I've seen in your video was not really tissue manipulation. Basically, with your left hand, you were pinning and pushing down the circle so that the tissue could not move. What the surgeon would do instead would be to pull it up and look what's behind. And I'm making this example because this is where the difference is. The tissue not too rigid is the limitation of all this attempt of automation of everything, because it's moving, it's changing, the shape is changing. And this is where the challenge is. Otherwise, to make a circle like you did, I'm pretty sure that with a little bit more of effort, you would do it very, very easily. But this would not help the surgeon then in the end. And the same goes for the examples that you have done with the needle holder. Again, we were missing the left hand. With the left hand, you want to understand if the needle is passing through all the layers and not one more of the layers that you really want to pass the needle with. But this is the direction we have to go. So I really want to congratulate for the third time with what you have shown, because this is really the closest attempt to something realistic I've seen. And going back to the question that you were asking, so where are we with automation and where do we want to go? I think in the beginning, 10 years ago, we all wanted and had the dream to make a full automated procedures, but this is absolutely not realistic. And if we want the robot to give a hint and be very precious to surgeons, improving results much more than already robotic technology allows, we have to concentrate on the difficult maneuvers for surgeons today. And there are many in the dissection part and in the reconstruction part. And I think if we not really automate, but if we advise the surgeon where to go, where to puncture with the needle holder and so on, that would be already a great advantage for us. I think we have to be much less ambitious than we were in the past. And we have to segment the procedures, analyze which are the difficult parts to be done hand-free, and work on those.
I'll just quickly respond because thank you, Alberto. I completely agree with you, and I just want to emphasize, and you know, we want to be very clear about this, that we do not see this as solving the problem by any means. It's just a stepping stone to getting to the directions that you're talking about. And I think the point about deformation of tissue, of perception of tissue, and when tissues are in motion, those are critical questions, and absolutely that's why this is such a hard objective to reach.
To me, it seems difficult to understand why very complex procedures like the suturing of the urethra during a prostatectomy, which is where the robot really makes a difference compared to laparoscopy, is still not automated. So the question comes from the surgeon to you now. Sorry if I take this liberty. In that case, you have two tubes that have to be approximated. And seems not that difficult to be done, in the sense that there is nothing that hides the view, and the deformation is, in my opinion, limited. Wouldn't that be a good environment to practice?
We'll try it. It's interesting because anastomosis, I see that as a holy grail. If we could do, I mean, actually, I think one thing would be great to discuss more is what are the interesting tasks. I welcome that, because I think, you know, we work with a surgeon here at Berkeley, but I would love to get your input, Alberto, and hear from others as well. What are interesting tasks? You know, I agree with everything that's been said, and Michael Yip has been looking at suctioning. Very recently had some paper at ICRA, which is beautiful, a new task as far as I'm concerned for robotics. So I'm actually really curious, where else, what would be good tasks for us? That is a very important question.
But Alberto, just a question for you, but why do you think that the robot would be better than a surgeon in doing this? So what is the advantage of making this part done by the robot? You're muted.
You're muted, Alberto. You're muted.
It's the same difference when you try to suture a dress and you do it with a sewing machine. The thing that you do in an automatic or semi-automatic way is repeatable, reliable, reproducible. What you do by hand cannot be. And I think that for instance, it's years that I try to limit my suturing. Whenever I can staple, I prefer to staple for the same reason. And I think we should go to a surgery that is reproducible. And so happy to use staples when we can, but we know that staples have huge limitations. They do not seal. There will always be vascular, or in any case, hydraulic anastomosis to be done that have to be completely liquid tight, that have to be done by thread and by hand. This is, in my opinion, a good example to start. Also because, as I said, you don't have anything in the view. So you don't really need to reconstruct things before by CT scan, MRI, or whatever. I think you can use fiducials somehow and be driven by that. I think there are people who want to
Alberto, I have a question, I mean, about this. So actually you are, let's say, a virtuous surgeon in love with technology, but I was wondering, are surgeons ready to receive this kind of technology, like semi-autonomous or autonomous suturing? Do you think that your colleagues, the ones that are not involved in research, are ready to accept this kind of technology?
I think that those that will have to choose when you will be ready will. Yes, I do. I don't think this phase will be that short. And therefore, I'm confident that the market will be ready when the device will be on the market.
I had a question here. If you have, there's something of a trade-off between programming a computer so that it can control sort of existing instruments to do the anastomosis versus having a specialized tool. Suppose you had a specialized tool that would, you'd have to change tools, but it would do the end-to-end anastomosis for you. How much time would you be willing to spend changing this other tool and getting it all set up in order to have it do the that one step in the procedure?
The answer is, it depends how crucial is that part of the intervention. In a prostatectomy, everything rotates around the suture on the urethra. It's the only really difficult part. So I think if a prostatectomy would benefit of such a device, no discussion that everybody would adopt it. Of course, I'm not a neurologist, but looking from behind, this is my feeling. But I would say the same also if you do, for instance, low rectal cancer surgery. Today, we know that this is very challenging. And to be honest, this is done now oncologically much better and with good results, thanks to technology, thanks to laparoscopy, and now thanks to robotic surgery. But we also approach those lesions transanally. Transanally, everything is difficult. Miniaturized robots to do that are clearly the future for these kind of anastomosis.
And interestingly, that's probably one of the sorts of environments where some of these high dexterity end effectors, these snake-like end effectors, could have significant advantage because you get high dexterity kind of mobility in a compact area. But it's always seemed to me that we do have this trade-off between us roboticists often like to emphasize the general capability of a robot that can be programmed versus the more specialized capability of a tool. And both really do relate to autonomy. So I think it's an interesting trade-off that we face. If you had, I mean, picking up on what Simon was saying, if you're doing a Da Vinci style surgery, what would you feel about having the camera completely controlled by the robot to give you the view you always, it thinks you need?
I would be excited, absolutely. And to be honest, I think there is one step before what we are discussing today here about automation, that is defining no-flying zones and preventing errors. If we already achieved this is, so if I would redo the scale of I wouldn't call it the scale for towards automation that Guangzhong Yang prepared for scientific robotics. But the achievements that I expect from robotics, the first is determining no-flying zones or preventing errors. The second is semi-automation. And the third is automation. Then you can decide task autonomy, all the other subsets of each. But these are the three steps that, in my opinion, we have to achieve, and in this order, to be honest.
Sure.
It's interesting, in my opinion, is preventing error.
From the robot point of view, the no-fly zones are fairly straightforward. We've had what we call virtual fixtures for a year, but that's still extraordinarily difficult because the perception problem, especially with soft tissue deforming organs. So that's, I don't know, maybe some other people could comment. But it's interesting that from the point of view of control of the manipulator, you can say, hey, stay out of this zone. The challenge that we have is figuring out exactly where that zone is relative between the robot and the patient.
If today you should monitor the movement of a robot intraoperatively, which technology would you adopt? In the past, I've seen using CT scan, MRI, ultrasound, more recently just imaging. More recently, I heard about the use of hyperspectral imaging for understanding the depth behind the surface, and also terahertz. Who has experience in this? And do you think you can match this to control automation of robots?
I have an opinion, but I've talked too much. Maybe one of the other panelists could answer that. Come on, Ken, where are you? Or Simon, or
I talk too much as well.
Yeah, but I've been talking more than you have, and you always have interesting and exciting things to say.
Simon is probably concerned not to disclose too much of what they're doing. Or
no, I'm struggling a bit here with my phone, Zoom issues. But well, so yeah, so I think there are a couple of interesting things there. One is, would an algorithm need to use the same kinds of inputs as a human is using, and would the algorithm need to use the same kinds of instruments that the human is using? And there's actually a question in the chat about, when we think of automating things, do we want to automate them in the same way as a human would do them, or do we want to kind of step back and say, well, what problem are we trying to solve? And, you know, if you're going to automate this, would you do it differently than a human would do it? And that might mean that an algorithm could see better in infrared or in some other band or some combination of bands simultaneously that a human cannot do. A robot might interact with tissues more effectively using a very different kind of manipulation end effector. And so that could be an interesting way to be thinking about this problem as well. Like, are we just trying to follow the way that humans do it, or are we able to actually solve the problem better by thinking about the problem?
Simon, don't we have to do it this way? Basically, do it as human does, because the human. So if you're going to gradually give autonomy to the machine over decades, so that you bring the community with you, and it's not, and there's always a fallback to human control. So it's like, let's say, designing cities. If you were to have self-driving cars, you may have designed the streets in a different way. But now we are stuck with what we have, and we want to gradually go and manage this mix of driver-driven cars and machine-driven cars. So yeah. So I think that's I personally think we have to actually do it the way humans currently do, to be always able to fall back.
I agree. I mean, that's clearly an important point, but there's some elements that could be done that could be compatible both ways. So for example, if there are multiple imaging modalities, or the imaging modalities that a computer could use more efficiently or effectively than that a human could process, those could work side by side, right? A human could be seeing in white light, whereas an algorithm could be seeing in infrared, just to pick an example. So there might be some ways where they could coexist. But I think it's a good point. You make a good point.
So this is nice. This nicely connects to the topic of this workshop, which we're talking about, this holistic view. I mean, the question is that if we want to look at both the control and the autonomy and perception all together, would we do it differently or not? And I'm very happy that this topic is brought up already here. So I mean, I would suggest to talk a little bit about this topic, because I think that's a very important question. That should we think about solutions, autonomous solutions, based on what we already have, and we try to step by step improve it, or should we think about the holistic solution, which takes into account, which we zoom out and then zoom in again, and if the current current state of the art allows us to have this zoom out, zoom in phase now, or we need to go step by step? That's, I think, a great question. If any comment on that, I would like to. I would appreciate it.
If we think about small startup companies, unless they, I guess Intuitive was once a small startup company. It's usually easier for them to bite off a discrete piece of a problem. But I think in the end, we've got to think about the entire cycle of treatment. I mean, even going beyond just the operative piece. And within the context of say, even within the context of surgery, I think you kind of need both. I think you need a systems approach that defines the interfaces so that better discrete solutions to particular elements can be introduced. I mean, these successful surgical robots, I would say the Da Vinci is an example, are to a great extent platform technologies. They provide basic capabilities that you can then modify. In that case, it's mostly so far been with tools and a little bit of visualization augmentation. So I think we need to actually be spending more time on all of this, but the issue of perception, of having a situational awareness on the part of the computer controlling the robot that is shared with the surgeon is, I think, one of the major barriers right now. But
any other opinion?
So maybe I can just say something. So it depends also on the scenario that we are targeting, because up to now we are speaking about minimally invasive surgery, but then we can also think about other scenarios, for example, endovascular surgery, or let's say structural heart diseases problems to be solved through endovascular robots, or for example other robots dealing with soft tissue and so catheter insertions and so on. In those cases, I think that autonomy is most straightforward, because they need to follow a path, and then the interaction with the surgeon could be, let's say, that the surgeon defines just the target or the targeting pose, the final pose of the catheter, for example, when implanting a valve, and then the rest is autonomously done by the robot. With this respect, I think that the integration of sensing and intelligence is fundamental, because the robot has to be aware of the environment, and of course, the surgeon should see from outside what the robot is doing inside.
Yeah, I would add orthopedics to that list of places where I think there's been, early adoption of autonomy of certain aspects, right?
2 comments on that, Elena. First, semantic. I would not call that surgery because you don't use 2 hands. You just have a catheter, but that doesn't matter. It's interventional for us, but it doesn't really matter. The key point is that this is effective for the patient, and it is. The second thing I want to say is that we have to, one of the limitations that I try to explain always to my students of the current robotic platforms is that they try to mimic laparoscopy and also our body shape. We have a shoulder, an elbow, and a wrist. We have to get rid of that, and catheters are probably the future. So now all the systems that I've been seeing today are based on the iSnake technology, in fact. So infinite degrees of freedom potentially, and I think we have to get out of this mechanical construction of robots, and then definitely we need to sensorize them and focus only on the tip of those catheters, which we will actuate in a semi-autonomous way. But the autonomy of the catheters, of the shafts, of the tentacles, call them as you like, it's obvious. That's something that has to become completely autonomous, also because we don't have the habit to control those kind of shafts that do not correspond to our anatomy.
That's a very okay. I think Elena, you want to say something? Yeah, I just wanted to mention that's a very interesting point that you're making, Alberto. So I think from the robotics point of view, and then considering the focus of this panel, infinite degree of freedom is great in terms of the mechanical compatibility with human body and minimizing the damage to the human body. But it increased the complexity of control, because first you need to have multi-point shape detection and force detection often, which is now kind of possible with using FPG and new continual optical measurement now. But then the control is very complex. So, and that's, I think, one of the area of research, how we can think about making autonomous flexible robotics, dexterous robotics, which is actually the topic of this talk, taking into account the complexity of the mechanical design, which imposes the complexity to our control and autonomy. So this connection is very interesting for me, and I think that relates to your question. So if any comments from the panelists and you or anyone else who can comment on that would be great.
Yeah, Farouk, I agree with you. And actually, question about this, do we need to have fully autonomous systems like snake-like robots, or we can also develop some shared autonomy strategies? And in this case, which kind of control interface? So we have also to take care on how the coming back to the talk of Russell, so we have to take care about this human-machine partnership. So how to mediate between human intention and action. So if we are going towards shared control strategies for those systems.
And Franny, just to add to your question, I think I would add, how do you manage the handoff of control between a human and the machine? So what part is done by the human, what part is done by the machine, and when does the machine delegate the job back to the human, or the other way? So actually, we were in another workshop, and there 2 examples were given where both relating to aircraft crashes. One was Boeing 737 MAX, where the machine took over and didn't let the pilot do what he thought was needed, and the other one, the machine gave the control back at a time when the human was not ready to take over. So how, for safety, how do you manage this handoff of authority or autonomy?
So if I may, there's a couple points I'd like to add. I think that trade-off, first of all, Madi, is very interesting. That we've actually been looking at this in a different context, because for other tasks where there's human supervision, where essentially you want the robot to be doing, these are non-surgical tasks, but essentially minimizing the interruptions to the human, and then reasserting control. And we define that in terms of its confidence. And so when the confidence becomes low, it will bring in the human. And then as soon as it's confidence, basically watching the human, and if its predictions are consistent with what the human is doing, then it feels it's confident to take over again. So we can formalize that. We have a paper on this called Lazy Dagger. I can say more about that. But I want to mention, Alberto, to your point about the snake-like robots. One of the big challenges from a robotics point of view, and I'm actually curious to hear from some of the many others in the room here, is the control itself. So if the snake-like robot, essentially, if you issue a command to that robot because of that complex linkage, it's very hard to know what the robot is going to do in response. It's not consistent. And to some degree, what's very interesting about the Da Vinci systems are that they are remarkably consistent. That you can, because of the linkages, you can actually, if you indicate a movement, a millimeter to the right, you get that movement from the system, and that's very important. But with the snake-like robot, you probably won't get exactly what you requested. And this is the world we live in, Alberto. So I understand and I sympathize with your frustration that the expectation from surgeons is, why can't we do this? I mean, we can send robots to Mars and we can beat the world champion and go. But these simple tasks are become very, very dependent on the repeatability of the mechanism itself. And that's where adding those extra degrees of freedom, there's benefits I see for the patient, but it adds enormously to the complexity from our side as roboticists.
Thank you for saying that. I was not aware. So I thought that the limitation was sensorizing those snakes, whether you here are mentioning really the consistency of the action that you generate. Now I understand why some videos were pretty poor. I thought it was just because of prototyping. It's the control, not the hardware, the problem.
So the sensor was part of the equation. Yeah, sorry, Simon. Do you want to go ahead?
No, I just had a quick follow-up question on that for Alberto. When you think of snake-like devices, are you thinking about snake-like devices to gain access to anatomy where you would still perform kind of mechanical, physical tissue interactions? Or are you thinking about kind of paradigm changes towards energy-based or ablative approaches? Because I think then this question of precision of control might be a little different. If you have the ability to reach some portion of the anatomy with a snake-like device, but then have precise control over the delivery of energy, for example, then perhaps it doesn't matter that you don't have millimeter level precision on the snake, right? Because you need to get in roughly in vicinity of the tissue. So I'm curious, when you're thinking of flexible devices, how do you envisage them?
No,
for the kinds of things that you're trying to do, clinically.
I envisage both because I'm a general surgeon, but also a flexible endoscopist. So I see the applications to both area. But you're right, and this also allows me to specify another thing that I wanted to say, that in the session before, I heard someone saying that he could get that precise in dissection that he can separate disease cells from healthy cells. Again, this is raising the level too much. Let's be more practical now. It's oncologically safe to have a dissection of a tumor, depending which kind of something between 1 millimeter or 5 millimeters or 10 millimeters. We don't really want to separate diseased cells from healthy cells. And no oncologist would accept also to see a tumor resected like that. He would consider it only partially resected. He would never believe that the dissection. So let's focus on more practical things. So yes, what I have in mind is, what it is my main specialty is that to use natural orifices for performing really minimal invasive surgery, and therefore I think of eye snakes, also snake-like robots to get inside the body from through natural orifices. The precision, even in that case, the precision that we need for dissecting a large tumor in the rectum is not that much. So I think that an approximation of 1 millimeter would be absolutely tolerable. What we perform today by hand is definitely less precise, in my opinion, than that. So it would be already more than acceptable. I don't want to switch now to another topic, but I did not see much of soft robotics in this session. Is that because controlling and automating them is more difficult, or because you still don't believe that you can have same strengths? Wouldn't it instead be easier probably to control soft robots in certain environment?
That's a great topic. I think that can be a good next topic, the control of soft robotic systems. I can connect that to the previous question. I'm very happy that we have also a surgeon on this panel, because that helps us to talk about the solution that we can have and the translation of the clinical translation, which is an important aspect in engineering. So thinking about the rigid robotic solutions and flexible solutions or soft solutions, when it comes to control, it's basically the difference between walking or flying. I mean, the complexity is much higher. And theoretically, we go from, in theory, in math, we call it going from ODE to PDE, which means that you increase, as you perfectly mentioned, the degrees of freedom to infinity. So it is possible to control a soft robotic system, flexible robotic system. There has been a lot of amazing examples in the market. But I think the question that Simon mentioned, I'd really like that question, is that if you, for example, as a surgeon, tell me that I want this soft robotic system or flexible robotic system to have the accuracy of 0.1 millimeter, that would be very difficult. But if you tell me that I want my robotic system to be compatible mechanically, doesn't damage the tissue here and there, but then I don't care much about the accuracy because I am the human in the loop, taking control telerobotically, right? So the two have two different control solutions. Again, I'm trying to emphasize on the control, which is the focus of this panel. So they may sound the same, but they're very different from the engineering standpoint. So that is why these comments are being different here. So again, Alberto and Simon, and I think Russ wants to also mention that if you want to comment on it, and also Ken, on this topic, that would be great.
Yeah, a few things. First, I think it's important to make a distinction between accuracy and precision of motion here. A lot of what we're dealing with, even with mechanical surgery, what you really care about is the relation between the tool and the tissue. And if you have some kind of a feedback loop, it could be your own eyes, it could be some automatic perception thing, you can close a loop around that. In that case, it's really, can the robot make very local, very precise motions to correct for whatever errors it's seeing between the tool and the tissue. I think the other point, which I really liked what was just said, as you add flexible or soft robots, the number of degrees of freedom goes way up, which means you have typically you have a lot of redundancy. And usually, let's think even if you're teleoperating, what you're usually wanting to say is something about how you're wanting to move the tool, the end of the business end of the system. But then the computer can decide what it's supposed to do about the rest and to take advantage of that redundancy. And it seems to me a lot of times when you think about it, what you really want to specify is sort of an envelope. Here is what the rest of the robot is. Can't go out of that. It's sort of like your no-fly zone, your safety zone. And so you stay within that tube or that envelope while I'm locally doing something here to the tissue. And that becomes quite a challenge. For instance, in some of the orthopedic things where we have a snake robot cleaning out a lesion from inside a bone, to help control things, we put shape sensors embedded in the snake. But even there, occasionally you need to take you need to register to CT images and occasionally take X-rays to kind of correct for any errors that you're beginning to build up. So I think one of the challenges and the opportunities that we have with these more highly redundant systems, the snakes, to some extent the soft robots as well, really comes down to we've got to rely on the computer to manage more of that. I think with the soft robots, they're inherently less precise. It's harder to tell it to make a very small, accurate, precise motion. But perhaps other people may also have some thoughts on that.
Actually, on that note, can we open it up to input from the rest of the group? Because I would love to hear. Pierre, I see Pierre as well. Bob Webster.
Yeah,
there's a number of experts here, and I want to shout out to my postdoc Minho Wang, who is
sorry for jumping in, Ken. That's the topic of the general panel, by the way. So if you can actually join, we want to have every person. So yeah, basically the questions that Alberto mentioned, soft robotics, like having even Bob Webster has the robots that you wanted to work with, so he presented those. If you can join the last panel, everyone can actually comment. But right now, yeah, if anyone wants to comment, please feel free to do that.
But then I have a question to Simon. Simon, from regulatory point of view, how far are we from automation and full automation especially? So what's the company view of that? Because we are talking about science theory, but then when this is available, would you be happy and ready to market something like that, or is it too risky? Or
yeah, that is a big question. I mean, the best I can do in answering that question is to describe a little bit of how we think about risk today, right? Because we're going to have to somehow map the mechanisms that we have for assessing risk into very different kinds of systems as we think about autonomy, right? So, so this you may be aware of this, but sort of the way we think of risk today is that there's kind of a top-down way of looking at that, and there's a bottoms-up way of looking at it. And the top-down way of looking at it would be, for example, to think about what are kind of clinical requirements and risks. So you might ask a question of, what if a vessel is not sealed completely? What is the effect of that? And you could ask that of kind of the human kind of performed version of that, and then you would land on kind of the tools being an issue, or the UI being unclear, or things like that. If it's an autonomous agent, that question becomes a lot larger. Like, what does it mean if the vessel were not sealed completely, and what could the reasons be that might occur? A second would be around the usability requirements and kind of risk assessments around that. So for example, a question would be, what if a surgeon is confused by a particular prompt or unclear on how to move an instrument? And you could say that maybe in an automated sense, that part goes away. It's actually more about the algorithm's perspective of what to do next. But as we spoke of earlier, if you've got this back and forth transition of control, then there's a usability question of, does the surgeon know when they're in control, or who's controlling what, between the algorithm and the user? So that's sort of a thought around sort of the top-down thinking. The bottoms-up approach is something that's more likely to be kind of a failure modes and effects analysis, which would be, what if a particular sensor fails? What if a particular part of the device fails? What might occur, and how might you mitigate that concern? So kind of rambling, but it gives you a sense of the way that we think about risk today. And some of those approaches might be amenable to thinking of automated approaches, and others aren't. So for example, some things that are new challenges would be that many of these algorithms are based on learning patterns from data. So then you have to ask, where did the data come from? What is the provenance of the data? What is the completeness of the data? Is there bias in the data? Did you train it on the broad range of patients that you would expect to see? Is there potential for manipulation of that data? Are there potential attack surfaces? So it becomes a very different kind of problem when you're starting to think about algorithms that are being trained on data. And I think we're going to need new ways to think through that. And so that's kind of not a complete answer, but I think it starts to kind of point at some of the challenges.
Yeah, and about this topic, I was also wondering if one problem to transfer automation in commercial robot can be also the problem to ensure a meaningful human control over autonomous systems. So how we can ensure a good supervision of the human when we have an autonomous system. So here, I think that also control interface plays a crucial role in this. And also, what will be the, let's say, responsibility chain? So if something goes wrong, who is the fault is of the surgeon or of the robot? So I think that also some ethical and legal issue comes here when we talk about autonomous robot, and even semi-autonomous, depending on, let's say, the level of autonomy. So we have always to ensure a meaningful human control. And I think that this is a crucial point also. What do you think?
Sorry, just to add to the previous thread, that's something I've been thinking about recently, is how do humans learn, right? So we have kind of a similar case, and I'm curious if Alberto sort of thinks this is a useful analogy, but you think of a medical student, someone who's learning to perform a procedure. And what do? You kind of give them lower risk, lower stakes parts of a procedure to manage. Like they might hold a scope, they might hold a retractor, they might hold a suction irrigator. And you kind of build trust over time by testing their ability to perceive what's going on and make decisions in lower stake manipulations, and then gradually give them more and more autonomy, more and more control. And so I think perhaps this question of understanding risk and regulating kind of ties in nicely with this idea of layering intelligence into augmented intelligence and autonomy into these kinds of procedures layer by layer in a way that we can build trust, not only as a kind of regulatory community or a clinical community. So I'm sort of throw that out there.
Can I follow up just quickly on that, Simon? Because when you talk about training, I'm thinking about these, the fundamentals of laparoscopic surgery, something like these test kits, and we've always been going under the assumption that those are stepping stones that are used by surgeons, and so are a good way to evaluate progress. It's obviously, it doesn't involve any animals or danger to any living beings. But I'm curious, do you think that there's a limit fundamental? Is that a viable approach to sort of work your way through those increasingly complex set of tasks? And I think this point of Farokh said about the holistic view, because it is a matter of being able to integrate the perception and the control, and to do it reliably. I mean, to earn the trust. I think to address these risks that you're talking about, I think that the idea is that if you can demonstrate this on the phantom tissue with a high degree of reliability, then does that start to move in terms of raise the confidence or reduce the risk?
Yeah, I think there's kind of two things that we're trying to address here. If we think of something like the fundamentals of laparoscopic surgery, what it's trying to help a surgeon learn our technical skills, right? How do you manipulate tissue? Then, of course, there's the layer of cognitive skill as well. How do you make a decision when you look at a vessel? Is that the right vessel? What step should I do next? And those kinds of phantoms are not trying to teach that. And so a resident or a fellow is progressing and they're learning both technical and cognitive skills. And an autonomous agent may need one or the other or both, depending on what you're trying to automate. And I'd argue that perhaps the cognitive aspects might be a lot harder because you need to have models of tasks, you need to have some familiarity of the patient's background. There's a lot of experience in that. The technical skills are hard, but perhaps more tractable depending on which technical skills specifically you're trying to automate. So I think we have to think of both, right? The technical skill piece and then kind of the judgment cognitive piece as well, right? And the second one is harder to test with kind of phantoms and inanimate models.
My point of view is more or less the same, but slightly different in the sense that I think that first really the student has to acquire technical skills, and that's the role of the FLS. And only after that, when he knows exactly what happens when he moves the wrist right and left and so on, then he has to approach reality environment. And it doesn't really matter if they are virtual, if they are phantoms, or I still think that virtual has limitations, but the job that Intuitive has done is fantastic. And I think that there should be a long phase on that kind of trainer. And then possibly make a step in between before clinical application in doing some inanimate model. For sure, I don't want to see any more using animals for that. I mean, we have all been trained on animals, and I think it's something that it's the first focus of our research today, to avoid using.
So that's a great I think topic. Now I would like to actually connect a couple of comments here. I think there's an echo. So I would like to connect a couple of comments that Simon, Ken, and Mahdi mentioned, also what Alberto mentioned, which is very interesting. So thinking about training robotic system now, for example, again going to the autonomous car example, like it has been shown that because of the bias in data with autonomous cars, sometimes the possibility of a white male getting hit by a car is much lower than a person of color who's not male getting hit by a car, autonomous car. So, and that shows the bias in data, as Simon mentioned. And then now we're talking about the training environment for robotic systems to make them autonomous and to avoid situation, for example, like Matthew mentioned about the airplane problem. So what training environment, data collection environment we should prepare or we should design to provide enough examples to make the robotic system, to train the robotic system, or to design automated algorithms. The current system that we use are the same that we use for training novice surgeons. Are these systems, are these phantoms enough for collecting data with enough of diversity and heterogeneity to train our robotic system? Again, I'm trying to have this holistic view connection of different aspects of autonomy. So now I'm thinking about the data collection. If somebody can comment on that, would be great. How we can remove the bias and how we can collect enough representative data for training our robotic system.
For the training for training a system, you need to collect data. Data collection is becoming a huge problem, and in Europe we have some initiatives for acquiring data, sharing data. So because now also there is the big problem of the privacy issues. So data needs to be properly anonymized, and then you have to respect the ethical requirements of protecting data. So to avoid leakage of data, who's gonna use the data, and how this can be guaranteed that data are safe and so on, and so also kept safely. So once you overcome all the limitations due to privacy, and you're able and you make clinical center able to safely share data and distribute them about the community, and also to acknowledge that annotated data are really precious and really give a lot of power to algorithm to be trained. So once you have the possibility of sharing, then it's also to be from the data has also be properly annotated. So you have to make sure that they are complete with all the information needed and are properly annotated without making mistakes and so on. Once this is done, then the community could leverage on a big amount of data and properly trained autonomous system. So the ones that also Simon was mentioning before.
I actually have a question to add to Farooq's question. Sorry, I'm asking questions, not answering any. So is there any regulatory approval framework for autonomous systems? Or do you have to just prove that these autonomous systems are as safe as non-autonomous traditional systems? Is there anything specific for autonomous systems developed, like by FDA, for instance?
That's a great question. Perhaps Simon can comment on it, if possible.
Yeah, I don't have, not really close enough to that to be able to give you an intelligent answer. I'm curious if there are others in the audience that are a little closer.
So in the previous workshop, there was this interesting conversation because so industrial robotic system, the current or the older standard for industrial robotic system was the robot shouldn't share the workspace with humans. So typically industrial robots should be kept in cages. You open the cage, they should shut down. And the question is that how we can design new standards like ICRA standards or different types of standards for having more intelligent or collaborative robotic system in the area of medical robotics, and in this case, dexterous surgical robotic systems. So if anyone is aware of any effort in that regard, I think that can have a major impact on the field.
So, I mean, one thing I would say based on trying to commercialize some of these systems is I don't know of any specific guidance on autonomy from the FDA, but what I can tell you is the FDA is still grappling with robots in general, like how do we approve them? And they have just recently decided that all robotic systems should go through the de novo pathway rather than the 510K pathway. So if they're making these big structural decisions on how you even, what pathway you even approve robots through, I doubt they've drilled down to the point where they're saying parsing autonomy versus not. But I'll tell you, in general, when you're going through FDA approvals, you're not actually comparing necessarily against the risk of a manual procedure or not. What you're doing is you're laying out all of the risks, like everything that can go wrong, and then you're ranking those in terms of severity level, like will it kill the patient, will it harm the patient, like what is it? And then you're taking the ones that are high and you're trying to squish them down to an acceptable level, which you determine, and then you submit to the FDA and you see if they agree with you. So all of that would apply to autonomy. You just rate the risk of it, which is sort of a qualitative judgment, and then you think of all the ways you could possibly mitigate that risk, and you make an argument for how you minimize that risk as much as is feasible and is safe enough. And it's a little bit of a squishy standard, but that's kind of how it goes.
So Bob, let me ask you, I mean, that's really valuable. When you want, isn't it possible to quantify this by, say, experimentally, you could perform a procedure, 100 times or some number and actually get data on it in terms of how reliable the system is, or is that not trusted by the FDA?
No, that kind of data is exactly what the FDA would want to see.
Okay. So they want to see it. I mean, I presume that's what happened with the Da Vinci history and others that have been approved, that, it's a long path of showing each step from the mechanism reliability, then all the way up to, through animals, etc. It's, and I wanted to also note that the data, so we're talking about data and, this is what you have to submit to FDA, but it would be so nice to have data sets in the field. And I know the jigsaws that Greg Hager put together with Simon was really has been very heavily used and is very, very valuable. And I would encourage others to put those together and publish them, because they are very useful to be able to analyze segmentation, as Alberto was saying, for example, and try to move toward this cognitive understanding of the perceptual problem. So those are lacking right now.
And I'll point out that Jigsaws kind of falls into that category of something that really captures more of the technical, the technical elements of interacting with Phantom. And so where there's really a large gap is data sets that show large amounts of variability in actual patient procedures, right? Where you're trying to understand, can I actually train to that variability, right? Because it's not going to be repeating the same procedure on the same patient 100 times. It's going to be repeating, different procedures on different patients, many hundreds of times. And I think that is the challenge. And then to Elena's point, many impediments there related to sharing of data from a variety of perspectives, including privacy aspects.
And Simon, I think one thing that I can also add is that we should probably educate ethics boards that we shouldn't show that we'll destroy the data at the end of the study. Not only will not destroy it, we'll keep it, we'll share it. So I think that's something that we also have to deal with at the university level. At least that's what we have to show now.
Yeah, and I guess understanding what potential unintended consequences might occur, because that's what they're sensitive to, right?
So that's a great conversation. So as the last question, I think we are getting to the end of this panel. I have a question because I know there are different types of autonomy. People with different background in autonomy are here in this panel. So if you want to train a robotic system to do surgery, part of the surgery autonomous, do you train robots based on the observation from the surgeon, and or do you let the robot try to do experiments and fail like an RL thing, and then learn by its own? Is it like an optimal to let the robot learn on its own, or it's better to let the robot learn from demonstration of surgeon and then generalize it? So which one and how we want to comment on that, and what you think about the future of both fields? I mean, they can coexist. I'm asking, what's the future of both of these directions?
Well, I would tell you that my first response is that's kind of self-exploration of reinforcement learning. You don't want to be doing that on the physical robot. It's just too fragile. And I've already had to bother Simon multiple times to replace arms that we've crashed into things. So I want to keep that to a minimum. So it'd have to be done in simulation. And then this comes up to the point that Alberto's saying about training, because then the simulation is never as good as the real system, and you have the sim to real challenge. So
and more importantly, you wouldn't want to be doing this on a real patient.
Right. Sorry.
The robot can be replaced.
Yeah, and Farrokh, sorry, please
go ahead.
I just want to say.
Go ahead. I'll stop.
Sorry, yeah, I just want to say, agree with you and say that, in general, I would go with anything that's kind of physical modeling based and then add data-driven things to it, or go with, let's say, imitation learning from demonstration, or some sort of model-based control, and then add data-driven things to it. So, sorry for cutting you off, Ken.
No, I agree with you, and I think that's where there's real opportunity is the imitation, where using demonstrations from surgeons. And Alberto, let me ask you: do you feel comfortable having your surgeries recorded and potentially shared? If, let's say, you and the patient would both agree, I'm just curious if you and the fellow surgeons would feel that would be acceptable.
I am in a privileged position because I'm in an academic institution, and all my patients sign a consent that their procedures are recorded for didactic reasons and research reasons as well. And we are struggling today with the Department of Video Imaging, because they know very well how strict the privacy issues are in Europe. Hey,
Beverly?
As well.
Beverly? Yo, it's going to take me a minute or two.
So we face the problem, but we still do it. And we have a software to anonymize everything automatically. And of course, we take them in our laptop for our congresses and so on. So we are ready to do that. And also to share it, no problem. And I also want to say that my vision of solving the issue of how to teach the robot how to do things properly.
Okay,
tell me one thing that we tried together with Fanny and a number of absolutely outstanding scientists recently, and unfortunately failed. It was a proposal for the European Commission to sponsor us to set up a project in which we wanted really to teach the robot how to do things properly. And that's why I mentioned before the errors. So the main goal of that project was to avoid the errors during surgery and train the trainees by letting them try the first clinical procedures with a robot that had on board all the capacities to prevent errors. And how did we want to teach the robot to do it? By recording not only the images of the videos, but also the geometry of the arms during the entire procedure, so that we could understand which were the actions that led to errors or near errors, as we mentioned. So not really critical situations. And I think this is the approach to go.
That sounds to me to be extremely hard, however.
It is.
Yeah, I think before we get to errors, I mean, you might see particular skills taught that way. One of the challenges, I think, with all of these machine learning methods is you need to know when the patient in front of you is well enough covered by training examples. And that right now is an unsolved problem in machine learning, especially these deep nets, which is what people are mostly using for this kind of skill acquisition. I think in the end, there clearly are pieces that we can learn that way, but for things like that, I think I would probably start with a relatively low risk task like endoscope aiming or something like that, where the consequences of guessing wrong aren't so bad. And then you could then begin to adaptively even learn a particular surgeon's preferences.
Okay. I'm really sorry to interrupt you, but time is over. But please hold on and join the next panel, the general panel, so we can continue the discussion. And I just want to ask you to fill the pool that we have the link on our website. So we have prepared some questions, and we would like you, so panelists and also audience, to answer, because we are trying to prepare also a review paper with all these open questions, and so it will be great. And please, please reach.
Fanny, my battery is about to die, and my wife is wanting me to go, so I'm going to miss the general panel. But let me just say before you close, I thought this was a great panel. I was very skeptical about the way you were going to do this, but I honestly think this is I've learned a lot more than I ever do by just watching a bunch of talks.
Thank you very much.
Thanks, Ross. Thank you. I appreciate it.
Thanks. Coming from you means a lot.
I agree.
Bye-bye.
That's great.
Bye, Russ.
We are going just to have other two videos, and please join the last panel.
So just before we go, Fanny, I put the link for the poll in the chat. So if you haven't left it, please click on it and participate in our poll. That would be great, and we'll be in touch with you about that. And after that, we are going to see you in the general panel. And
one more thing.
Close that. Give it to Farshid. Farshid is all yours.
One more thing. So we asked the same questions from other panelists regarding what Ross mentioned. We want to get your feedback on this new format that we tried, right?
You already did.
Typically, okay, yes. Just want to know, what do you think? Because we plan to have on the same topic, number 2 and 3, hopefully, if it gets accepted in the next workshops. So what did you feel about this discussions and recorded videos? Obviously, if it's in person, we can do like talks and then discussions. And we would love to hear your feedback.
With coffee.
This is new. Yeah, with coffee. So any comments, critics, concerns? So we would love to hear that.
I think it
Ken,
went
go
very
ahead.
well.
Yeah.
No, I think I like the format very much. I think it's a great idea, and that gives us time to. One thing I've learned in the course of the pandemic is how beneficial it is sometimes to learn from watching videos rather than live experience, and that is the ability to watch it maybe at a faster pace or to rewind, and to be able to watch at your own comfort level. So I like this a lot, actually. It may even be better when you're live as well. We could watch them over lunch and then come back. So I like it a lot.
Okay, cool.
And add that maybe having access to those videos prior, right? So that, as Ken said, folks can play them at double speed and think about them right before the session might be a useful tweak.
Sure.
The approach.
Great comment. Yeah.
We do our best. That was partially from our side. We started a bit late. Sorry about that. But hopefully next workshop. Elena, do you have anything to add?
Just that I liked it, and yes, the possibility, maybe, also the possibility of having this video recorded also to show to students. I think that would be a great possibility. And yes, of course, I think that the panel would benefit now of some coffee, of in-present discussion. That would be more fun, I would say.
For sure.
Definitely.
Sure. So any other comments before we go to the other talks?
Matthew also and Albert.
I just want to ask, where is the general panel? Can you put the Zoom link? Do we stay
It's
on?
the same. Yeah. In 30 minutes, hopefully. After we have 2 more videos, very interesting videos from Dr. Barker Ahmad. And Dr. Arezzo, he has actually very nice, actually medical related talk as well. Please watch it. It put me in breakout room. So if you just click on the breakout room, you can watch it. And in 30 minutes, we'll be back with
on the same link.
Finalizing the session on the same link. Yeah.
So we'll see you here in 30 minutes.
Right. Thanks so much.
Thank you.
Thank you all.